Hi guys, it's a pleasure to be speaking with you all today. I thought we'd start today with a question. How do you know when central pain sensitization is occurring? So just to stop me having to say central pain sensitization every time, let's call it CPS. So how do you know when CPS is occurring? What is it in the history that tells you? What is it in your physical exam that tells you? To answer that question, I thought we'd go through a case. So this is a real case. This is the last new patient I saw before the lockdown started. Unfortunately, she has a terrible case of asthma as well. So not only was she my last new patient, she was also the first one I had to tell not to come back. But it's a really good case to go through. So it's a 54-year-old woman who presented with chronic, severe left hip pain. She was born with congenital hip dysplasia, or as she described it, congenital hip dislocation. So she's always had hip problems, she's always had hip pain. But she's tough, and she's muddled through. However, when she gave birth to her first child, things started to get worse. She had a second child fairly quickly after, and about 14 months later gave birth the second time. And at that point, her hip really started to cause severe daily pain, chronic daily pain. Follow exams with x-ray and bone scans showed severe osteoporosis, and it was recommended that in her late 40s that she would have in her 40s that she would have a total hip replacement. So obviously quite severe. She says that for the first 2 or 3 months, actually the pain was better. Not gone, not a cure, but better than it was. Unfortunately, this poor woman was in an abusive relationship, so we won't go into details of that, but imagine all the stress and all the horrible stuff that that does to the brain and body. And then she fell and slipped on some ice, landing hard on her low back. Now, the hip surgery was a complete success. The surgeon was really happy with it, and when she fell, she didn't damage that hip at all. It was her low back that hurt. From there, the pain just exploded. So I can show you her, her pain description. So she said originally the pain started in that left hip, in the anterior hip. That's where the pain always was, but in the posterior buttock as well. After the second birth, that pain started to spread down her leg, going all the way down to her ankle. Once she fell, she hurt her back, then that the central low back. And then the pain started mirroring her left leg, started spreading down her right leg. This pain down in the ankle is unfortunately because her movement, balance, and posture is so affected, she falls a lot. She said that she falls almost daily, and when she fell, she managed to rupture her right Achilles tendon. The pain then started to spread from her low back up into her upper lumbar, lower thoracic. It then jumped up to her neck, across the shoulders, and down into the arms. So in terms of what do you see when you're looking at a history of CPS, chronic pain, that's kind of it. Pain that starts in one place, and then generally will follow the dermatome down, follow that dermatome down into the limb. As the pain gets worse, it may start to mirror. So if we were to say, I hurt my left shoulder, let's say I've got a supraspinatus strain, we will always get primary sensitization in injured tissue. That always occurs. So by primary sensitization, we mean that when we touch, it's more painful than someone that's not injured. Pain pressure thresholds. So if I'm poking myself in the chest, I can poke pretty hard without really reporting any discomfort there, any pain. If I've sprained my supraspinatus, what we'll see is, with much less touch, I'm more likely to say that's painful. And you're going to see that in any injured tissue. That's not a problem. That peripheral sensitization is part of the healing process. These little nerves become more sensitive to say, lay off me. I'm repairing this part, don't hurt. The secondary hyperalgesia, which is an indication of CPS, starts to occur, or we know it's occurring, when tissues adjacent to the injured tissue, so non-injured tissues, start to hurt. So I injure my supraspinatus, but now actually when you start to poke around infraspinatus, that actually really hurts too. maybe moving down over the lateral part of the shoulder is painful. Maybe I start to see that my biceps, actually, when you squeeze that, so that's really painful. So generally, it's going to affect areas that are of the same dermatome. So if it's 5-6, anything that is receiving that 5-6 is going to hurt too. And then it will start to spread down the spinal cord. So that's that CPS. I'm telling myself I want to use that CPS, and yet I keep trying to say the tongue twister. So if you think of your segmental levels, obviously 5, 6, 7. So the pain starts to spread inferiorly normally. So that means the patient will say, originally, let's say the pain was in 5, then it started to go down 6, now it's starting to go in 7, 8. So the patient basically will say, it was just my shoulder. Actually, now I feel it quite a lot in my hand. And when you can identify that by doing your pain pressure thresholds in that same area. So really, this shouldn't hurt, right? Not really. Might a little bit tender, but it shouldn't hurt. CPS is present when you squeeze these things, and they really do hurt when the patient, starts to yelp. That can spread the whole way down the spine. So let's say it was my shoulder. First, it will go down to the whole arm. Then it will go into my thoracic spine, lumbar spine, down to my leg. So the patient might say, and I'm sure you've seen this, it's my whole left side. It's just my left side's crap. It always hurts. And when you palpate, you'll find, that whole left side is painful. The goal is to identify where was the primary cause. Where will that pain start, and then figure it out. Patients with reduced pain pressure thresholds will, for a shoulder injury, will report reduced thresholds all the way down in the foot, in the anterior tibialis. It's a really good thing to look at, and it really gives you an indication of, on that pain scale, where this patient is. Is it just a little shoulder sprain, they've had it for 1 or 2 days, or is this a deep-seated, central pain problem that's going to be really hard to treat? So in our case, Mrs. C, where she's got this, horrendous pain going down both legs, across both buttocks, starting to travel up her spine, and that's a really bad sign. If the pain starts to travel up, that's another indication. It means that the brain is the one starting to change now, because generally the pain should spread inferiorly. Where do you start? So with this kind of case, this was a referral from another chiropractor. So, and that's another clue to your history, right? A patient who's seen everyone. That's never good. That's never good. We don't want to hear that, right? When they say, I've already seen a physio, chiropractor, I've had acupuncture, I've had pain meds, I've been to a pain clinic. That sensitization has already occurred. So where do you start with a case like that? I won't say all examinations, but virtually all, nearly all, with gait. So to have a healthy gait, you need a good cardiovascular system, musculoskeletal system, strength, balance, endurance, rhythm, posture. You need a good visual system, vestibular system, and proprioception. You need a good sensory system, motor system, and good sensory-motor integration. So anything that changes any one of those systems is going to change gait to a greater or lesser extent. So gait is a bit like having a good look at the wood and not just zooming in on the tree straight away. Have a look at the wood, identify which part of the wood is the problem, and then start to look at individual trees. With this patient, when she walked into the office, she was, no exaggeration, bent over like this. She had a walking stick in her left hand, because obviously that's not a stable position. As we know from her history that she says she falls most days. So when you're looking at gait, when it comes to an antalgic gait, generally patients lean away. So if it's foot, ankle, knee, or back on the left side, generally people will lean away to take the weight off it. When it's hip, however, often they lean towards. It's just to do with biomechanics. It offsets the pain, offsets the loading. So she's leaning heavily towards that side. At the same time, you see a heavy hip drop on that left side, and she's got all kinds of crazy compensations. Her gait is short and shuffling and very wide-based. The core features of gait, because there are so many things you can look at gait. Look at the core features. What is the stride length? What is the speed? What is the width? you don't actually need to know the specifics. You have seen enough normal people to know what normal gait looks like and to recognize an unnormal gait. So reduced speed, it has a highest correlation with falls. So if someone walks in and you ask them to take 10 steps or as many meters as you can, if they look like they're shorter steps than normal, if they've got slower than normal, that's the highest risk of falls. A shortened stride is the same, and a wide base gait is anything wider than 10 centimeters. So wider than 10 centimeters, we know they have a problem with balance. You may not know why they have a problem with balance, but we know it's there. It makes sense, right? If you think of any of your back pain patients, your real acute back pain patients, they don't just stride into the room, and look healthy like they're striding out on the moorlands. They look like they're in pain. That's basically what you're looking at for the core features: reduced speed, reduced stride length, wide base. On examination for her, those pain pressure thresholds were so severe that just running your thumb, with no exaggeration, just running your thumb along her skin was painful. She has a massive scar from where she had that total hip replacement. So despite the fact the surgeon obviously did a great job and it was a complete success, you could be the best surgeon in the world, and even if you're using keyhole surgery, you still have to punch it through skin. There's nerves everywhere. So with her history of chronic hip pain and an abusive relationship, and 2 children who, for those who have kids, we know that's stressful enough, right? So for someone in that situation, any activation of pain is going to risk amplifying. So normally what happens is you have descending inhibition of pain. And if you were to look at a section of the spinal cord, let's say L5, the number of inhibitory pain synapses to the number of excitatory pain synapses, it would be inhibition to pain. There's a massive ratio difference there. Your brain basically is always saying, I don't want to know. Unless it's serious, don't tell me about it. Don't tell me every time I take a step, on a slightly uneven surface that's painful. I don't want to know about that. I want to know what the other sensations are like. I want to create healthy movement, and pain interferes with that. So let's inhibit pain until it's really serious. What's going to be happening with these central pain sensitizations is that ratio starts to drastically change. I've not seen any research that says it ever reverses, because that would be just horrendous, but the ratio dramatically reduces. So the number of inhibitory cells massively drops, and at the same time, the number of excitatory cells increases. So for this poor patient, it means as soon as best surgeon in the world, as soon as you cut through that skin, you're bombarding the dorsal horn with more pain, and that's a system that's good to go. So that slight injury, bam, that pain shoots up to the spinal cord, up to the brainstem, up into the brain to tell you she's suffering. But it wasn't keyhole surgery, it was a total hip replacement. So he's also had to cut through all kinds of muscles and a whole bunch of other nerves. You'll often see around scar tissue that it's incredibly painful, and if you ever feel it feels quite nodular. What you're often feeling there is literally neuromas. So where these little peripheral nerves were passing through the skin or muscle, where the surgeons had to cut through them, you get a complete transection of the nerve, which results in a neuroma. So a neurotomesis, which doesn't normally recover very well, especially if you've got a lot of scar tissue in front of it. But that neuroma itself becomes very, very painful. So that's why even just running my thumb along her skin is severe pain, 9 out of 10, just for something as simple as that. So that's the primary cause of the pain. When we look down the rest of her leg, all of it hurts. Not as severe as that primary, but everything else, even the sole of her foot is enough to get her to have a withdrawal reflex, want to pull her leg away from you. So we know that pain system is super, super angry and is really, really aggravated. So in terms of treatment, where do you start? If I can't even touch her skin without causing her severe pain, and the last thing I want to do is amplify that. I don't want to do anything that's going to produce more neurological, cellular, genetic changes that when she leaves my office the next 2 or 3 days, she's still sensitizing. So where do you start? I'm a big fan of, I borrowed this from Ulrich Sandstrom, which was calm things down, build things up. So in that case where she's so sensitive, the place to start is with your laser. you can reduce pain without even touching the patient. That's why I got one in the first place. I've had a few cases like this where they failed every other treatment, and you don't want to be the next guy on that list of failures. So the way I'll generally use it is I know the dorsal horn of the spinal cord has changed. It's not healthy. It's promoting pain way too much, and the inhibitory synapses are just not firing very well. Don't have the strength in numbers, and maybe don't even have the health to do that. So you can do it a few different ways. I would put it on the dermatonal setting. And then basically, if this is my spinal cord, you've got options. You can either paint up and down, or you can do this. Or for some patients who it's important that they feel some patients want to know that you're doing something, not just, a bit like ultrasound, you can't feel anything. So sometimes with some patients who are a bit more, needy is not the right word, but you know what I mean. I'll sometimes just place it on the spine, and the machine, if you don't have one yet, gives you a beep. So it almost gives you like a count. So identify the spinal level, place it on there, and basically wait for the beep. And then I'll move it down one level, beep, down one level, beep, down one level, like that. I might do that 2 or 3 times. We're then going to change the setting onto either a pain setting or onto a universal, and then we're going to come over the injured tissue, over the primary area. So for her hip, my hand doesn't look anything like a buttock, I hope, but let's pretend it was. Let's pretend that's her glutes. This is out towards the trochanter, and this is more spine. Then we're going to paint, and the way I'm going to do it is it's going to be 1, 2, 3, and I'll do at least 5 passes, but probably I'll do more like a minute or 2 minutes, depending on how severe it is. If it's just primary sensitization, I will only do 5 passes and move on to something else. The treatment is quick. In somewhere where it's more severe, I'll do a couple of minutes. I'm a big fan of pre and post testing. So what I want to do with her is, before I use the laser, is tell me, how sensitive is that? Give me a number. Then use the laser and immediately say, and now. If the pain is reduced, then that's fantastic. Now I can do something else. I have permission to maybe try and work on those neuromas, maybe try and liberate some of those peripheral nerves. The peripheral nerves, basically, if you compress a peripheral nerve, it's going to become sensitive very quickly, but the blood supply to a peripheral nerve is very delicate. So if you have any muscles, any fascia, any scar tissue that is compressing that nerve at all, I say liberate the nerve. What I actually mean is just get the blood supply going again. Get it so that it can remove toxins and debris, get lymphatic drainage. So use the laser first, calm things down, check that the patient is able to tolerate that, and then if you can, try and liberate some of those peripheral nerves. If anyone has ever done the FNOR course, so the Functional Neuro Orthopedic Rehab, that's a great course for explaining things like neurogenic inflammation. So I would leave that to those guys because they do a much better job. But down in the hip, you're going to be looking at things like the superior, middle, cranial nerves, and basically just learn your anatomy, learn where the nerves are, learn where they track. And when you look at the scar tissue, try to think, okay, well, what nerves go through that area? Where do they start? Where do they leave the spine, and where do they go to? And just try and work that area. I would use, in her case, we used vibration on that first session. So again, vibration is going to be way too painful for that primary area. So we start on the secondary area. So I started way down on the foot. If you think that normally what happens is sensation comes in and it suppresses pain at that spinal horn, dorsal horn, apologies. So I want to drive things that normally suppress pain. So vibration, you want it very quick and you want it light. So you're not pummeling the patient's foot and producing pain. It should be a nice experience for them. So start on the foot and then slowly work your way up through the leg, up the dermatomes, getting as close to that scar tissue as you can without aggravating the pain. So with her, laser, try to do a little bit of soft tissue work around those neuromas. Vibration, so that's calming things down, and then we want to build things up. We want to activate the brain to sending inhibition. So the frontal areas of your brain that are to do with planning, problem solving, and joy inhibit pain. So we want to give her some kind of task that makes her think, makes her plan, makes her problem solve to get that descending inhibition and start to try and rebuild those healthy synapses and get rid of those unhelpful ones. So I had her lie on her side. We know through that hip drop and through her terrible gait and through the surgery that glute medius is weak. She had a grade 3, so she can hold her leg against gravity but not against resistance. So I had her lie on her side and just lift her knee up. No resistance because she can't do it. And I'm aiming for a minute, but I don't want her to feel guilty or weak or stupid. So we just say, hey, let's try and do 10 seconds. If you can do more than 10 seconds, keep going. So 10 seconds, 20 seconds, 30 seconds, and I did that 2 or 3 times. That's me trying to build things up. That's what we did that first session, because I didn't want her to react badly. Again, without exaggerating, her gait honestly was like this the first time. When she stood up and started walking, she was upright. Her gait speed had improved. It wasn't perfect. Her stride length had improved. Again, not perfect, but much better. Enough for her and her teenage daughter to give you one of those, oh my God, this is so much better, which is just the joy, right? That's what we all want to see. We don't want patients getting up and going, oh, yeah, it's a little bit better. We want that, yeah, oh my God, I feel so much good. And to impress a teenager is always a delight. So, and that's what we had. So she walked in absolutely reliant on the walking stick and walked out, laughing and thanking me profusely on the way out. That is absolutely a case where I think using the laser is essential. So I've seen cases like that before where I didn't have the laser and I've just hurt people. And I'm not going to say I couldn't help them. People, as long as you're doing the right thing, get better. But it took a long time and there was lots of ups and downs. And I feel like the laser, especially in cases like that, just gives you the ability to take a hands-off approach and say, I can still help you. In severe cases, I might not touch them at all. Just say, that's all we're going to do for today. You're just going to come in more frequently than normal and we'll just use a laser. In the research, they'll often use laser daily. But treatment is really short. So the patient literally comes in, you just check everything's okay, use the laser for a few minutes and the patient's gone. So if you do need to get them in daily, it's not a massive chunk out of their day. They're not spending half an hour with you. My appointment's normally a half an hour, so it's a decent amount of their time if they're taking time out of work. But if they can just come in for the morning for 5 minutes or the evening for 5 minutes, then that's not so bad. Let's recap. I tend to speak fast and I tend to get excited, so let's just recap on what we said. So primary sensitization is going to occur in all healthy tissue, not healthy tissue, all injured tissue. Secondary hyperalgesia occurs when central changes start to occur. And generally, you're going to see it spread down through the dermatome. So if it was C5 originally, it will become C6, C7, C8, T1, then it'll start to spread down the spine. Equally, if it started in say, the hip, you'll start to see it spreading down the leg. You know things are getting very serious when it starts to spread to the other side. When we call it widespread pain, that's not good. If you were to say, look at low back pain, mild, non-specific low back pain will have higher pain pressure thresholds than someone with severe non-specific low back pain. Their thresholds will be higher, or their thresholds won't be as sensitive as someone with mild chronic low back pain. They won't be as sensitive as someone with severe chronic low back pain. They won't be as sensitive as someone with widespread pain, and they're not as sensitive as someone with fibromyalgia. So basically, the more sensitive you see, the more central sensitization you know, the more harder that case is going to be to get better, the more clever you need to be about thinking about how you're going to go about treating them, because there's a very real chance that you could make them worse. We've all had that person, right? Oh, I went to see the chiropractor down the road and he made me worse. He probably didn't do anything wrong. He hasn't permanently damaged them. Unfortunately, that system was already set to go, and he just he pulled the trigger. In terms of the exam, we just discussed that. So treatment, calm things down, don't aggravate it, and then as soon as you can, start to activate brain and muscle to try and get things stabilized. Right, I've already been talking for longer than I should have. I'm going to pass back to Rob so he can explain some of the science behind why that laser can be so effective in these cases and why it's of use. Great. Guys, pleasure to speak with you all. If you want to get in touch, please do. If you have any cases or questions, you can email me at jake@bcneuro.co.uk or follow me on Facebook, which is BC Neuro. I try to upload cases and videos on a pretty regular basis. During this lockdown, it's a little bit harder. So yeah, get in touch. Have a good day, guys.